So our topic today is interpreting pre-post changes in the qEEG. And this is an important topic that creates a lot of confusion. And I'm focusing this on NuMind Maps for NuMind Maps user, but it applies to maps in general in many ways. Most of the other systems out there don't have much of a pre-post comparison tool. I know Thatcher's had one all along, a basic one for doing students' T comparisons, and it's a good tool. We've created ours slightly differently. We're focusing more on a clinical audience, and you all are not that interested in the statistical details, but in the practical application of them and how to use a compare tool so you can get the most out of comparing a pre-map and a post-map. With all the confusion and theoretical differences that exist in the field, we're certainly not going to keep everybody happy, but we're going to keep pretty close to the research on this. The first notion that I want to get at is that normal, which is green on your map, on your head maps, when they're green, that means people are within a normal statistical range. That is a statistical concept, that it's not something about their character, it's not something about their conduct or their behavior. It's purely a statistical statement about the status of the EEG distribution on the head map. And green is a reference point. It's not the final goal. You're not looking to get every map green. That's not even realistic. What you're trying to do is move people towards the green and move them enough towards the green so that they experience symptomological changes. So here in front of you is a Gaussian distribution. Statistically, and this is a normal curve as we call it. The center, where that looks like that upside down U, is the mean or average score, and on either side is plus or minus 1 standard deviation. And then you notice yellow is 2, and then red is 3. In our map system, we use red for 2 and yellow for 3. We were following BrainDX's example, and we did that for a reason, because BrainDX will be available on our system, and we knew that since the beginning of the system. And so this fall you'll be able to access BrainDX norms, which is kind of the gold standard in the field. That was the first map system. But you can see the percentages here, that 68% of the population here is within 1 standard deviation, and 95% of the population is within 2 standard deviations. Now, in a lot of qEEG people's perspectives, they're thinking somebody doesn't have any abnormal activity until you get outside of 2 standard deviations. You know, that's such a small percentage of the population, that would where you would find abnormal behavior. Although that's true statistically, that's not necessarily true of a phenomenon's intrinsic nature. Most of the activity in the human brain occurs within the first 2 standard deviations. Most of the anxiety and depression occurs within 2 standard deviations. So we're more interested in what happens in that region than a lot of other qEEG people, and that's just our perspective. It helps us interpret clinical data better, and it correlates better with the psychometric measures and sociometric measures that we tend to use. So we're looking for people who are in the yellow zone, which would be red on our system, to move towards the green. That's the goal. Just get them moving towards the green. It's not to make every site green. So here's a representation. The arrows represent the direction that we're interested in moving towards the mean, or that middle line. Okay. So if you're doing a pre and post test, you can see over on the lower left side the movement that we expect. Somebody may be close to 2 standard deviations and move closer to 1. And as Martin is often fond of saying, there's a lot of action that takes place within a standard deviation, and you can get quite a bit of movement all within that standard deviation and get very close to 1. And that would be highly significant. But it might not show up on the colors on the head map because, as you can see, they're almost ordinal measures. They're categories of 1, categories of 2. And you're moving within that category. That's important to keep in mind. That significant movement clinically, not statistically, clinically can occur within that 2 to 1 standard deviation region. Another notion that we really have to be clear on is that the brain moves towards green in iterations. It doesn't move in a linear fashion. Okay, people train. Some days they train well, some days they train bad. And their maps may move well for 20 sessions, move a little bit backwards for another session, move better for another. But even within each, group of sessions, whether it's 5 or 10, the brain is often moving back and forth. So each location does not stay normal while the other locations improve. All the locations are subject to changes at any point in time. So you may have P3 may be out at the beginning, get better in the middle, and get out again at the end. But everything may improve because all the other locations in general have moved towards a more normal position. And P3 was just part of a network, parietal network, that had to adjust that way in order for that movement to take place. So there's no start point and end point to change. And this has been repeatedly made an important point in the neuroimaging community. Honey et al. Wrote a significant amount on this point, that the brain is going through iterations. There's no beginning and end to the iterations. So the brain must continually reorganize to accommodate the whole. This accommodation in our system is called compensation, based on the research at Harvard University that we've talked about again and again and again. Compensation is the flip side of plasticity. And so it's impossible to predict the trajectory of accommodation as the brain operates in a critical state on the border of chaos. So your brain is so complex, it borders on chaos in all of its transactions. And it's impossible to predict the exact trajectory. You can define a vector space and a direction that things may move in generally, but that's all you can do. So the brain moves in iterations or cycles. Again, no start point and end point. The start point and end points are selected in time arbitrarily by the mapper. Each map will contain components of what was in the old map at each iteration. So you're going to see stuff that was in the previous map and some new changes. I have shown maps that are 10 years apart with no obvious change, and the only way you can see change is to look at the numbers, the statistics. So each map and each successive map may appear to move backward or forward with respect to the norm. Parts are moving forward and parts are moving backwards as the brain accommodates. Another important notion is that changes may be big and obvious or small and distributed. You may see, alpha go completely down across the board. You may see everything go down. Or you just may see little changes in magnitude, little changes in dominant frequency, little changes in coherence, phase. They all add up, however. And that addition of all those little changes can be an overall significant change. There may be no changes in any dimension but symmetry. There may be many small changes in each dimension. And that makes it difficult to determine what the change is without a statistical analysis, and that's why we use the compare tool. You may look at a map and say, this doesn't look that much different, but you look at the percentage of change and you see, oh, this changed 28%. That's pretty good. Changes do not have to be greater than 2 standard deviation to be significant in their consequences. The majority of activity and changes you'll see in maps occur within 2 standard deviations. As I said, you may move from close to 2 standard deviations out to close to 1 standard deviation out. Small changes within 2 standard deviations can precipitate and indicate major unseen shifts in functional dynamics. Do not underestimate the power of multiple small changes on overall brain dynamics. The present level of measurement does not allow for observation of micro and meso level network reorganization. What do I mean by that? Is that we do not have the technology in the neuroimaging community to detect and observe micro and meso level changes in network reorganization very accurately. Neurofeedback can only get at the meso level. We're looking at dipole layer changes. The micro level and the lower end of the meso level, we can't image, and you can get proxy ideas of what's going on through fMRI. We can look at fiber maps, and that might help a bit, but those are very complex, and we do not understand how fibers networks map onto networks. That's unknown at this point, still unknown. And Freeman says it may be more about looking at electrical fields than network systems, and that's not math or science we have really established yet. So these critical changes can result in major shifts in behavior. A change of 1.5 or 1.8 standard deviation indicates a large redistribution of energy. So when you get that change, that's approximately 1 standard deviation, there's a lot of changes in energy and network dynamics to accommodate that change. So although these changes appear to be in normal limits of possible activity, they may be abnormal in their dynamic range of change. So a lot of the change, again, in the brain occurs within 2 standard deviations. Most of the change does. At each period of measurement, the entire spectrum tends to initially shift up or down. This is not uncommon. Significant changes in any given frequency or component band may result in shifts in the entire power spectrum due to innate limitations in distributional dynamics. This is the consequence of compensation. It's also the consequence of limited plasticity when a brain has been challenged excessively and is not functioning at its full potential. So here you can see this map was all blue at the beginning, there on the first level, and then after a significant amount of neurofeedbacks, in fact, this was the 3rd map in this group, notice that most of that blue has come up. That was done through pure neurofeedback. There was nothing else going on there. So it is possible, if you're giving people good nutrition, they're getting good exercise and sleep, and you train them, that you can make the changes. But the changes that inspired that shift across delta, theta, alpha, and beta may have come from training only 1 or 2 frequencies. This person may be training SMR up and theta down. You don't know until you look at the record, but that will potentially cause a global shift in the brain and potentially could do something like this. It often doesn't. Usually you need 2-channel training or 4-channel training to achieve this kind of change. This was a 2-channel change, but it can occur, and this is profoundly significant. I mean, it's easy to see this change, but this person could have gotten close to that green, and all of that dark blue could have just turned light blue, and that still would have been a profound change. In this slide, you can see the magnitude shifts down globally in response to beta and theta, beta up and theta inhibit. So, we're training, actually, no, this is from beta and theta inhibit. So we inhibited theta and beta went down. You can see that theta is a little bit elevated and delta is a little bit elevated. And typically in this scenario, even alpha's a little bit elevated. And I usually tell people, train the theta down. Training theta down and beta up is similar to activation in an MRI paradigm. You're increasing blood flow and activity in the cerebral cortex, and by doing that, and Herschel Tooma and I demonstrated that 20 years ago with HEG, that you could train HEG and alter brain blood flow, and that would alter slow to fast wave ratio in the brain, and you would get very significant changes in the brain. And then the co-registration studies done over the last 20 years confirm that. So here you're seeing somebody training beta and theta, and all the other frequencies follow. And you can see everything's going down. Now, is that a problem? No. When that delta goes down that far, beta goes down much lower than usual. There's a compensation process there. If you continue training, the odds are is that that beta will begin to come back up because the brain is now recovered from all the inflammation that you see in delta, which is the high delta. It's recovering from the diminished capillary perfusion, which you can see in the elevated theta. And so we have more of that activity that's going to feed mitochondrial resources and allow the brain to produce a more high frequency activity because it has more energy, and that beta will eventually come up as the person recovers. Here you can see there's a 35% change with equal parts reorganization and normalization, and that's quite good. So there's usually significant movement away from the norm as a consequence of reorganization. In the old days, we would see brain maps and things would move away from the norm, like you saw that beta moving below the norm instead of just staying where it was in the previous slide. It went down in compensation to the diminishing delta and theta. This is called reorganization. In order to accommodate movement of regional frequencies toward a more normative range of activity, other regions may need to move away from the norm to compensate for change. Reorganizational accommodation may occur in one neurometric dimension to offset changes in another dimension. This is what we mean when you look at that meter that says reorganization. Coherence is primarily an accommodating neurometric dimension. What we see and what we read in the literature is the brain alters its communication levels in response to challenges. And when resources get overwhelmed in one area of the brain, the other areas of the brain move in to aid and assist. And that's called compensation. And you see that in terms of increased coherence and connectivity in the brain. So communication may increase or decrease between large-scale networks as represented by coherence in your map, depending on the local and regional load demand represented by the magnitude shifts. So you'll see shifts in magnitude showing general reflection of shifts in activation and changes in energy levels in the brain. And the brain will respond by altering communication patterns, and you see that in the connectivity. So magnitude shifts represent changes in mitochondrial energy utilization, depending on local and regional processing load demands. The more you use your frontal lobes to solve a problem, the more your brain is going to inhibit activities that push you more towards self-referential thinking. You're doing an externally oriented task using the executive network. You're going to utilize the default mode network a little bit less. It's not a complete abandonment. It's just a little bit less. There's a 15% change in energy. The salience network shifts most of the resources frontally. Magnitude changes, and there'll be commensurate changes in communications and coherence. You can see that. With people who are disordered, those patterns can become rigid and fixed. People may become more oriented towards the default mode system, less oriented towards the external attention system. And so there may be compensatory processes in coherence and connectivity to accommodate that more rigid and fixed pattern. And that's why you see those changes in coherence. A change in this analysis is measured in all neurometric dimensions. So the compare tool looks at all the neurometric dimensions. It's the total percent of change in standard deviations across all 5 standard major neurometric dimensions of measurement, which are magnitude, dominant frequency, phase, coherence, and symmetry, as measured in all 10-20 locations across the entire scalp. So when you're looking at overall change, that middle meter on your compare tool, that's what you're seeing. People ask me that all the time. And so here it is. You can always check the slide if you forget. It's the total percent of change in terms of standard deviation across all the 5 major neurometric dimensions measured in all 10-20 locations. So we get a sense of how much did everything move. And that was something that was not looked at very much until we put together the new mind map system, not in this way. But as clinicians, this is what we wanted to know. How much does the brain change between training sessions? How is it affected by distress in the family? How is it affected by the health status that they bring with them to the training situation? What factors impede or aid neurofeedback training? How much does the brain actually change when you train it? What's a good rate of change? What's a bad rate of change? Or insufficient rate of change? All big questions that we're not getting answered. There's no research or grants for it. So we tried to standardize the system and have standard measures in order to begin to at least get a glimmer of what's going on. And what we found was that the average range of change, I'm talking about that middle meter, overall change is between 40 to 60% toward or away from the norm in any given neurofeedback cycle. I take that back. We're actually talking about the normalization meter at this point. So the average range of change is 40 to 60% toward or away from the norm in any given neurofeedback cycle. Here, both these meters are at 50%. More typically, you'd see normalization at 40 and reorganization at 60. That's typically what we see in good progress in neurofeedback. That reorganization meter rarely goes below 40 or above 60, and the normalization meter rarely goes below 40 or above 60. And where are we getting those numbers? We're pulling them from the overall percent of change. So the overall change was 35%. What amount of that 35% change, what amount of the change was towards normalization? Well, in this case, 50%. What amount of the change went away, the other way, towards the tails of the curve? Reorganization. That was 50%. Well, what we found from statistical analysis of large samples of pre and post maps is that a fairly typical range of change due to neurofeedback training. These numbers I'm giving you are related to neurofeedback training. This rate of change can be measured at any given time during the neurofeedback training once several sessions have been initiated. So once you begin doing neurofeedback and you see significant changes in the trend screen, pre-post maps start to become valid. They're more like taking blood pressure or temperature than they are other kinds of measures. You're dipping into the stream of ongoing change in the brain and saying, what is the rate right now? How much of it's moving towards the norm and away from the norm? That is a constant and ongoing process. Remember I said, as Sonny said, there's no beginning and no end. And so we want to get a sense of that rate of change. The rate is greater than the average daily rate of change with individuals not subject to neurofeedback. So if you map a typical person from one day to the next, you won't see a change rate as high as you will typically with neurofeedback, because you're accelerating change in the brain through intensive operant conditioning and learning. Okay, and this is procedural or task learning. It's like learning to ride a bicycle, and it's permanent. The brain is growing new dendritic connections and altering networks and network dynamics. So you're going to see significantly more change than if the person's just going from day to day, not doing anything in particular. Now, if a person takes a drug, that will also escalate the rate of change in the brain, for the time period that the drug is having its initial impact on the brain. If you did surgery, you would see that same change rate. You see it in anesthetics. People often have an accelerated change rate going in a reorganizational direction, and often you see a lot more delta and theta in the brain until it takes a month to 3 months to recover, and that slowly comes down. But during that whole period, there will be all kinds of accelerated rates of change going towards the norm and away from the norm. Trauma can do the same thing. Head trauma can accelerate the rate of change in the brain. It's not always a desirable direction, however. What we found, looking at things, is that the brain changes on average between 5 and 15% on a regular basis. So your brain is always learning, adapting, and changing. And depending on the rigidity or plasticity of the brain and how much compensatory activity there is, it'll vary typically between 5 and 15%. Okay, so statistical samples of large numbers of brain not subjected to neurofeedback reveal that the average rate of change can be as low as 5% and as high as 15%. That's based on our stats so far. That number could change as we refine our samples, improve our targeting, and increase our N size, but that's where we're at now. Those with sleep disorders can exhibit changes as high as 20 to 25%. Okay, even higher sometimes. So if you have a sleep disorder, you're not sleeping well during the day, you're going to have higher levels of delta and theta, and perhaps even alpha, because you don't have much energy, and a lot more of the dipole regions and networks will be on idling and awaiting more energy food in order to gear up and process stuff. So you'll see that elevated pattern in somebody training. Now, if they have a sleep disorder, they may have lower levels of delta and theta in the morning and higher in the afternoon. Why is that? Well, because as you get into the afternoon, you will find that there's circadian effects. There's a big dip between 3 and 5, but that window can shift depending on what time you go to bed. It may be earlier, 1 or 2, and 3 or 4 in the afternoon, or it may be later, between 4 and 6 or 7. Again, it depends upon your individual circadian cycles, but that's roughly it. During that time of day, people with sleep issues can have their brain processes start to mimic someone on alcohol. And a lot of people with diminished sleep because of sleep problems can be driving, at a point of impairment, as if they've had 2 drinks or more, and they don't even realize it. And if you ask the emergency people and the fire department, they'll tell you that the majority of auto accidents occur in that circadian dip during the day, not late at night. It's during that dip. So be aware that peak periods of slow wave occur between 1 p.m. and 6 p.m. If you have somebody with a sleep problem, and a lot of people with anxiety and depression do have sleep problems, beware that if you map them, do the pre-map in the morning and their post-map in the afternoon, it may look worse, because the rate of change between their morning and afternoon map may be greater than the rate of change due to neurofeedback. Okay, so this sounds a little complicated. It is a little bit, and you can really get into the complexity statistically of it. But you can keep it simple for yourself by just remembering, try to map at the same time on your pre-map and post-map with each client. And I would recommend before 1 o'clock. because our research shows that you get a lot more variance in the afternoon and you get a lot more slowing, and it really distorts the map. So here's a subject with a sleep disorder baseline map. We did a pre-post map, okay? The pre-post map was, we did a map, we waited for a few minutes, we did another map, like 5 or 10 minutes later. Not much difference. We got somebody with a sleep disorder and remapped later in the day, and look at the difference. We're getting 27% change difference between early in the day and late in the day. Normalization is 36%. Sleep was doing them good. They may have had an anxiety disorder. The slow wave slowed them down. You wouldn't think about that, would you? Wow, my anxiety patient got better. Yeah, because you mapped from the afternoon, there was more slow wave activity, and it overwhelmed the beta activity, which reduced, and so everything looked better. Nope, it was just the map that did it. The amount of daily change is also a function of plasticity. As we said, a TBI or a stroke can reduce plasticity and the daily rate of change in the brain. So here's a pre-TBI rate of change. We're seeing 33% in that case, and 40% normalization. Okay, that was a good pre-post map. We've done a good job training these people. Those are good figures, 33 and 40. And then we look at the post rate of change, 23%. We did a pre-post map there, and their rate of change dropped down to 23%. Normalization was up. Again, that may be due to reductions in anxiety and increases in depression. So that's an interesting conundrum. TBIs can alter the rate of change on average. Trauma reduces plasticity and also increases coherence. So this rigidity is often observable in increased levels of global coherence. Increased coherence or communication is a means of compensation, as I said earlier, for loss of local or regional efficiency. And so here you see this same person pre-post connectivity head maps. There's the pre-map. Things were starting to look kind of clean, some red in theta and frontal beta, little blue in delta. And the post map, suddenly we've got a lot more theta hypercoherence and a lot more beta hypercoherence. So those areas were more stressed. They're increasing communication to compensate for the distress and loss of efficiency. And you can even see we've got some dropout in beta at T3, T4, which suggests that, there's a lack of input for memory and emotional valencing. Here's, statistical output from a statistical package that I'm using. And in order to get a sense of the average rate of change due to neurofeedback, we looked at, in this case, 477 high-quality 19-channel maps done on a brain master. And we ran these maps actually through NeuroGuide, just so nobody could complain about the quality of our measurements. And so, really high-end research-grade analysis system. And we looked at the change rate in the low 20% range, changes to indicate that lower than normal change due to neurofeedback. The change rate in the high 40% change tends to indicate higher than normal change due to neurofeedback. And change infrequently occurs at a rate of greater than 50%. If you look at the overall change percent here, you can see the median and the mode. The median is 37, the mode's 34. They're close. That's a good distribution. Standard deviation is 8.9. That's pretty high. So 8.9 above and below the mean of 38, which is also close to the median. The high and low rates are pretty big. Add 8 to 38 or subtract 8 from 38, you've got a pretty wide range of change that's typically due to neurofeedback training. So there are the numbers right there statistically. They're published with our n size. That's where we're getting our information from. The assessment of efficiency of training should be based primarily on symptom change. Very important concept. A symptom tracker should be primarily referenced for changes due to neurofeedback training. So up in the top chart, you can see a symptom tracker. It really shows you clearly the changes. The trend changes should be a secondary criteria for evaluation of change due to neurofeedback. So you look on your trend screen, and here we have a nice Brain Master trend screen where you can see both sides. And so both the blue lines are alpha. You can see them trending down very powerfully and coming together as they come down. It's a little easier to see on our software now because we designed it specifically to look at that stuff more clearly and give you different colored lines for left and right, and dotted and solid line left and right, and big numbers at the bottom, so you can track that more carefully, because statistically we've seen that's what we want, and theoretically that's what's leading to the biggest changes. So on the NewMind software, you can just look at the numbers and see, are we getting good trending numbers on asymmetry in beta and alpha, and then you can compare that to the changes in symptoms. And then finally, the third measure we're using is changes in neurofeedback, because these other measures help us understand the positive and negative changes we're seeing. So reorganization here is very high, and normalization is a little bit low. But we're getting a good overall change, 36% change. A lot of it's reorganization. But notice, in spite of the fact that a lot of it's reorganization, look how the symptoms are improving. So don't think of reorganization as negative. It's organization that's taking place within that 1 to 2 standard deviation a lot of time, and it's very positive. And every iteration of that reorganization will push a little bit more towards normalization in different locations. So that's the basic concept. Large changes in reorganization coupled with negative changes in symptoms may be contraindications. This can occur if you're seeing somebody who's not getting a lot of changes or going back and forth, and you can see this at the top, filtering and organization are kind of going up and down. It's a fairly straight line. Where we are getting anxiety and depression is starting at 8 and going down somewhat, but it's going up and down quite a bit along the way. This client was drinking regularly and taking benzodiazepines, even though they weren't supposed to be. There was PRN on benzos, but still, they were supposed to be not doing that, and they had agreed they wouldn't. And so we could see the reorganization and look at the symptom changes and say, there's backsliding a lot, and we're kind of flatlining on filtering and organization. Something's up. So you look at the client's lifestyle habits, what's going on in the family, at work, and what's nutrition like, and are they using any mind-altering psychotropic substances. So that's why we want to look at that. The rate of change often decreases as the number of sessions increases, and this is another thing that confuses people. Decreasing rates of change may indicate asymptotic limitations for further change at any given stage in a person's life. Okay, so people may begin to change less and less as they train more and more. Why? Asymptotic limitations may reflect either physiological or psychological limitations. Your client may not have the nutritional and physiological resources to change any more in a normal direction, or their psychological environment, psychosocial environment may be impeding them too. Somebody needs to leave a marriage, somebody needs to leave a job, somebody needs to change school, somebody needs counseling. All these things can reduce the potential of the brain to change, and so you will see change diminish over time, and that's an indicator that it's time to maybe back off of neurofeedback and focus on some other interventions. And that's the time when you as a professional say, is neurofeedback going to be an effective intervention anymore? If not, no, then you inform your client and they can decide on if they want to go someplace else. You are not required to tell them where to go according to the law. And I'm going to do a presentation on that. Really, what are your legal obligations based on law, court law, case law, and we'll talk about that in one of the upcoming presentations. And so you can see exactly what your responsibilities are, but you're not responsible for catching medical problems or for responsible for referring. You can, if you like, refer, but you don't have to. So we'll go into the ethics and the case law that outlines that clearly in upcoming stuff. Okay, rapid changes in EEG can be masked by changes, slower changes in physiology. We see this all the time. If somebody's backsliding a lot, look at your metabolic score. If it's over 150, like this one's 210, you're going to get a lot of backsliding. What we found is that the rates of change in the brain are typically faster than the rates of recover physiologically. So to prove that, we don't just make an observation. We take statistical data from good amplifiers, high quality data, and that's been well artifacted, and we used a system to look at that. We have data on physiological changes and data on changes in the ISI, social psychological changes, which include anxiety and depression. And we can look at, take a group of people, like people who are training for the first 30 sessions, and compare them to people who are training 60 sessions or more, and say, how much did they change? How much normalization was there in the 0 to 30 group compared with how much normalization was there in the 60 and up group? You've heard me talk about this, but I haven't shown you the statistics I draw upon. I did this like 2 years ago. I just haven't had time to write it up and post it on New Mind Journal. I will, but these are the statistics, and you can see that on the normalization, on the people in the first 30 sessions tended to be around 38, and the normalization on the 60 and up sessions tended to be around 33. And this is a t-test that we're looking at, so it's a good comparison of the two. And when we compared that, again, we found people who had higher metabolic scores tended to change along the same lines in terms of brain changes. Now, that didn't mean they were the same. This group that was on 60 and up had higher metabolic scores. And you can see that even at 60, the rate of change was still around 33, whereas the group that had lower metabolic scores in the 0 and 30 range had changes around 38. That's a pretty good difference between 38 and 33, but it's not enough to make a whole standard deviation, as I pointed out in some of the previous slides. So it is faster. Neurofeedback is faster. The normalization is faster. It's not statistically significant, but you will notice it, and everybody mentions it, that if you have a person with a lot of metabolic problems, they report their changes at a much slower rate, and the changes are diminished compared to people with lower metabolic scores. So again, we need to be careful about just looking at things purely statistically, and to look at things analytically and in terms of clinical application. Change is gradual. Backsliding due to metabolics or re-traumatization is common. The percent change norms are here. A low percent change is 20 to 30%. Usually external confounds like metabolic. Average change is 30 to 40%. A high rate of change is 40 to 50%. Average reorganization is around 60% on the first map. Average normalization around 40%. What's the best measure of success? Have the symptoms reduced? And do you have 30 to 40% overall change? That is a really successful run of neurofeedback. If you're getting that, that's very successful. That's how we've defined it statistically, not according to some untested assumption or theory, but this is the statistical truth. This is what we see in large samples, 500, 1,000, 2,000. When we're running these stats, that's what we're seeing. And again, successive maps can show decreasing reorganization. So it's not always easy to tell if the reduced percent of change is due to health problems or to the fact that they're reaching asymptote. And that's why we have the metabolic checklist there, because you can say, well, this person had a lot of medical problems. The statistics that have been reported so far in NeuMind indicate that that slows down their reported rate of change and slows down their normalization a bit. And so that's probably why they're getting that rate of change. Okay, so that is where we are on this, and